Good afternoon to all. My case is fungal orbital cellulitis by Candida albicans following snake bite, a rare case. Since we all know that poisonous snake bite is a medical emergency because it involves the multi-system, and whereas the orbital cellulitis is an ophthalmic emergency, orbital cellulitis is basically the infection of soft tissue surrounding the orbit. Fungal orbital cellulitis is basically will be in immunocompromised individual. Usually in immunocompetent individual, usually it not happens. So my case is a 10-year-old male which presented to the emergency department with low-grade fever, malaise, nausea and vomiting with drowsiness. He was having history of snake bite over right upper lid while playing 8 hours prior to the presentation, and he received first aid in the form of local wound incision locally. There was no sign of internal and external bleeding and no sign of no significant prior history of illness. On examination, patient was having low-grade fever of 100 degree Fahrenheit. Pulse was 108 beats per minute. BP was 90 by 68 millimeter of mercury and respiratory rate was 26 cycle per minute. He was having altered sensorium. On ophthalmic examination, right eye lid was having a periorbital edema with skin necrosis with mechanical ptosis. Extraocular movement and visual acuity could not be assessed because patient is in altered sensorium. Conjunctiva was having congestion and chemosis. Cornea was clear, anterior chamber was normal depth, and pupil was briskly reacting. Lens was clear and fundus was normal, and IOP with eye care was 18 millimeter of mercury. In the left eye, anterior and posterior segment was within normal limit. So provisionally, we came to the diagnosis of right eye preseptal cellulitis following snake bite. Patient was admitted to PICU, and anti-snake venom injection was started with injection ceftriaxone, antibiotic eye drop in form of moxifloxacin and moxifloxacin ointment. On systemic evaluation, there was no evidence of immunocompromised status. Hemoglobin was normal. There was leukocytosis, and blood sugar was 98 milligram per deciliter. Renal function, BTCT was normal. HIV and HBsAg was not reacting, and blood culture was sterile till third day. On second day of admission, patient was deteriorated systemically and was unable to maintain oxygen saturation, and patient was intubated. And also ophthalmologically also patient was deteriorated. Patient developed proptosis with 22 millimeter in the right eye with 16 millimeter in the left eye at 95 millimeter at Hertel's ophthalmometry, exophthalmometry. On lid there was worsening of the periorbital edema and skin necrosis. Conjunctiva chemos and congestion increased. Anterior chamber was normal depth but quiet. Pupil was 4 millimeter dilated and sluggishly reacting, but fundus was normal. So CT scan was done on the same day, and there was collection of the preseptal area with intra and extracoronal space in the superior portion of the right orbit, and there was inferolateral displacement of the eyeball. Incision and drainage of that inflamed area was done, and pus was removed, and there were, we did wet mount of the pus. There was pseudo-hypy with budding cells was there. In the germ tube test, Candida albicans was identified. On several dextrose agar culture, yeast-like colony, which was confirmed by Gram staining. So we came to the conclusion that the patient is having Candida albicans infection. So a confirmatory diagnosis we came to that he was having fungal preseptal cellulitis along with orbital cellulitis of the right eye following snake bite. By that etiology is Candida albicans. Patient was started on injection ephedrine B and natamycin eye drop with cotrimazole ointment. On fourth day, proptosis and periorbital edema started decreasing, but unfortunately on fifth day, patient deteriorated systemically and succumbed due to the respiratory failure. So poisonous snake bite is having multi-systemic toxicity, but various case report has shown the ocular involvement following snake bite. Other ocular involvement are angle closure glaucoma, acute anterior uveitis, optic disc edema. There may be the direct injury to the globe causing the open globe injury. There may be the conjunctival and corneal laceration. There may be endophthalmitis, vitreous hemorrhage and exudative retinal detachment. But fungal orbital infection are rare, and till now there is no cases reported so far. So possible reason of the fungal orbital cellulitis in our case may be the direct inoculation of the fungus in the preseptal and postseptal area. There may be the host inflammation in the response to the fungal infection from the conjunctival cul-de-sac, and there may be the concomitant systemic instability with antibiotic use. But there is no conclusive evidence of any of these theory. So fungal etiology should be kept in mind while treating orbital cellulitis patient following trauma including snake bite, and immediate suspicion with early microbiological diagnosis and prompt treatment are essential in the management of such type of cases. Thank you.
You said that fungal endophthalmitis is not reported in the literature.
Fungal orbital cellulitis following snake bite is not reported.
Following snake bite.
Yeah.
Because fungal or endophthalmitis.
Fungal is there, but following snake bite is not reported.
And where was the snake bite? Which part of the body?
While patient was playing, he fell down. At the same time, snake bite happens on the upper part of the lid.
That you should have told.
I,
You said snake bite, snake bite. So snake can bite anywhere.
it was there in the.
Snake can bite anywhere. So this, and the other thing was the treatment for snake bite initiated at the same time?
Locally, when patient was admitted to the hospital, then it was.
Okay. Which hospital the patient was admitted?
At Jipmer, Pondicherry.
Huh?
Jipmer, Pondicherry, yeah.
Jipmer.
Yeah.
Oh, you are here in Center for Sight, no?
Currently now, center of sight.
Center for Sight. So I was just trying to relate because I thought that maybe it happened here in Patna only.
Yeah.
So, but you mention here preseptal cellulitis.
Yeah.
But it looks like orbital cellulitis. So,
Yeah, initially-
whatever way, if you are not confirmed, but as per your representation on CT, it is a huge collection and it is a proptosis like that. From clinical presentation, a full orbit is involved. So, you should not utter that word preseptal. Preseptal is only preseptal. There is a definite characteristics point is there for preseptal. And orbital, there is some movement problem, everything is there. So better you can say is a orbital cellulitis. You are in a safe mode.
Yeah.
No problem.
Good
Good,
case.
good.